Hey everyone, before we get started, this is Dr. Faisel Sayed, and welcome back to Faisel and Friends, a primary care podcast. We're excited to partner with Primary Care for America to help address the primary care workforce crisis. This is an issue that affects all of us, and we're here to make sure it gets the attention it deserves.
That's right, Faisel. Primary care is the backbone of our healthcare system. It's the only specialty where greater investment leads to better population health outcomes. But here's the reality. Without real investment in our primary care workforce, minor health issues become chronic conditions, further overwhelming our system and driving up costs. The shortage of primary care physicians has serious consequences for both patients and physicians, and we need more PCPs, especially in underserved areas. If we act now, we can create healthier communities, lower cost, and make a lasting impact.
Primary Care for America is shining a much-needed spotlight on this critical issue. They've just launched a new webpage, fact sheet, and graphics toolkit to help us all spread the word. Check them out at primarycareforamerica.org/workforce.
I'm pumped for today's episode because we're diving deep into this topic. Earlier this summer, we sat down with Dr. Yalda Jabbarpour, director of the Robert Graham Center, after her eye-opening presentation at Primary Care 24. Her research on the state of primary care workforce is a call to action we can't ignore.
Absolutely. Her insights are a wake-up call. We have to do something now. We hope you enjoyed this episode, and we invite you to join me and Dr. Dan in amplifying PCFA's resources on our social channels. We can't lose sight of how crucial a strong and diverse primary care workforce is to our future. Hi everyone, I'm Dr. Faisel Sayed.
And I'm Dr. Dan McCarter.
And you're listening to Faisel and Friends, where we believe access to primary care is a right, not a privilege.
Faisel and Friends is brought to you by Primary Care for America, a diverse collaboration of innovators leading the way towards comprehensive, continuous, and coordinated primary care.
Today, we're talking to Dr. Yalda Jabbarpour from the Robert Graham Center about investing in the future, healing access to primary care. Let's get started. Oh, Dr. Dan, it's good to see you.
Good seeing you, Faisel.
And my God, look what we've got over here today. Dr. Jabbarpour, thank you so much for joining us.
Absolutely. Good to see you both.
Good to see you. We were all just together just a few weeks ago in Washington.
That's right.
And we loved your presentation so much. And usually we like to start off our podcasts with a question, and then the conversation kind of goes from there. But today, earlier today, Dr. Dan and I were talking. And Dr. Dan, do you have the question that you fed into Open Evidence?
Yeah, so I knew we were going to be talking about the health of primary care, and I was looking at some of what you had written, and there's the study out that shows that you add 10 primary care physicians to a population, you increase the life expectancy by 51 and a half days. And I asked Open Evidence, well, what are some interventions that do the most to increase life expectancy in a population? And it came up with coverage of antihypertensive medications, smoking cessation, comprehensive management of congestive heart failure, and diabetes management as the top 4. Now, the question is, how do those things happen without primary care doctors, right? So, and those all have massive improvements. I mean, I've got the numbers here somewhere, but anyway, what are your thoughts about the state of primary care, and how do we get the word out about how important it is that it needs to be a priority at the national level?
Yeah, it's a great question. I think, since both of you saw me speak, that it's going to be a grim state that I propose. So, and that has nothing to do with us as primary care physicians. I actually think the primary care physician on the individual level is doing a fantastic job and probably doing more than they can to help with the health of the U.S. population. It really has to do with the support that the federal government, the state governments, health systems at large are really giving to primary care. And that support right now is really lacking. And, what does that mean? What does that mean for the future of the U.S. population? We can't continue to work in these systems for very long. You saw my presentation about how 10 years ago we were sounding alarm bells that we didn't have enough primary care physicians. And now with a sicker, older population, instead of that number inching up, it's actually going down. And I think that shortage has a lot to do with people retiring early, people burning out and leaving full-time practice early. And why are they doing that? Because we're not supporting the primary care system the way that we should.
I was in one of the offices at ChinMed this last week when they were discussing hospitalized patients. And I think there were 13 patients out of 2,500 in the hospital, which, by the way, in my mind is pretty good because these are pretty old, complicated, sick patients. But I think it was 8 of the 13 were over the age of 80, and they all had like 5 or 6 medical problems, and 3 of the people were homeless. And I mean, these are not what I consider the simple patients from residency 30 plus years ago, that you were treating hypertension, you were treating diabetes, and maybe the complicated patients might be on 4 medications, and now that's the run of the mill. So it seems like it's even more important to have well-trained primary care physicians to be able to care for these patients for our entire population as we age. Being one of the aging population members now, it's important to do that.
Yeah, absolutely. And I think you bring a good point. I mean, we have to be training the future physician to take care of really complex patients, not just medically complex, but socially complex. I mean, social complexity now becomes something that enters the primary care space that the primary care clinician needs to take care of. But without the support, without the team behind them to do that, it's really hard, as you know.
I was with one of my neighbors, and he was talking about he's a very patriotic person. I live just north of Tampa, Florida, and he was talking about about America being so great, so great, so great, and I said, yeah, America is great, but we're falling behind in life expectancy compared with the other developed nations in the world. And I'd love for you to share a little bit about how we compare with our investment in primary care. We don't have the social net, the safety net that many other developed countries have. And so we're all trying to figure out how to manage, like Dr. Dan was saying, with having a case manager go find a patient under a bridge. Literally, we had a meeting this week to find a patient. But how do we compare with some of the other developed countries, and what would you say would be some of the lessons that we could learn?
I think it's a great question, and you're right. I think during the pandemic, everyone's life expectancy went down. It wasn't just the United States, it was countries all around the world. That makes sense. The difference is that everyone has bounced back. So the US started lower in life expectancy than all other developed countries. We dipped like everyone else in terms of life expectancy during the pandemic. Everyone else quickly rebounded, and you could see that rebound was really timed with when the vaccine was readily available for developed countries. The US continued to go down. And so I think that has a lot to do absolutely has a lot to do with primary care and our primary care infrastructure. I mean, Dr. Dan started the conversation saying he looked up what saves lives in the country. Everything you said, that is the function of primary care, right? All that prevention, all that treatment of those chronic diseases. And so our life expectancy is likely lower because we don't invest in a strong primary care infrastructure. We know that most patients in the United States, when they're seeking care in their lifetime, will see a primary care clinician. Most patients are not going to the hospital, are not seeing a specialist, are not going to the ER. But even though we're the backbone of the system where most people seek their care, we are not spending that much money on primary care. So for an example, it differs, but we're spending anywhere between 5 to 7% of total US health expenditures on primary care. Despite us being the backbone, we spend so much on healthcare, more than any other developed country we spend on healthcare, but only 5 to 7% of that pie is going to primary care. Compare it to other nations where they are spending double that, even more on primary care, and then look at their health outcomes. It's not that hard to draw the line between investment in your primary care system and life expectancy, right? And I think, to add to that, it's that lack of investment in our primary care system. That we're not talking about paying primary care doctors more. That's not what we're talking about. We're talking about actually investing in our offices, in the infrastructure for primary care, so that primary care clinicians can do the work that they need to do. They're not, doing all the administrative work. They're not being bogged down with having to be the social worker for their patient. They can be the primary care physician for their patient because they have a team behind them, because we've invested in the practice. So I think it all goes together.
And I know you've got some ideas on training, not only getting more people to go into primary care, but then where and how to train them, because we're talking about working as teams, right? And I feel like a lot of times when I go in to help out in one of the centers that I don't usually see patients in, it's like if you were on a sports team and you're being put on the field with people that you don't know. And so, I think we're running to the left and they think we're running to the right. And then I'm standing there by myself. I mean, I was standing there with two pretty sick patients one day and everybody had gone to lunch. And I'm like, oh, what happened here? And, we should be planning for this, but there are ways to do that. So what are your thoughts about that? How do we train people to be able to be better team leaders if it's going to take a team to do this work?
Yeah, I think that even a step back from that, how do we train people to do the job that they are going to do as primary care clinicians? And that's not necessarily this really intensive hospital-based training that all of us do, right? I know that we all had to have continuity clinics in our training, but most of our time, if you look at it, was in the hospital. Now, in the hospital, we certainly did work with the team, didn't we? You had the entire team around you when you were rounding. You could call the pharmacist in, the nurse sometimes rounded with you. On the inpatient side, we got it. And then we're kind of thrown into the outpatient side, community-based work when we graduate. And none of our training was really done there. We did some training there, but not really, right? Like, you ran from your inpatient clinic to half day of outpatient continuity clinic, and it wasn't your focus. But then it becomes like 80% of what you do, and the inpatient becomes 20% of what you do. And I think first we got to start with really investing in training our primary care residents in the community where they are actually going to be working. And then secondly, getting more specifically to your question, we need to be able to move our payment systems in those clinics so that they're not purely fee for service, right? Because if they're purely fee for service, you don't have the infrastructure, the financial infrastructure to pay for a robust team to exist in that environment. And if a robust team can't exist in that environment, then your trainees are not getting any exposure in terms of how to work with a behavioralist outpatient, how to work with a pharmacist outpatient. Even some don't get training on how to work with an RN outpatient, like all the things an RN can do that the physician doesn't have to do. So I think, moving training into the community, funding that training in the community, and then changing our payment systems to allow for teams to take care of patient needs and not doctors to just provide services is really essential if we want to train our future workforce to be team-based.
Yeah, many of the residents, they don't have that experience when they're going out. They're seeing it was a tough situation pre-COVID, right? COVID was rough, and now post-COVID, they're seeing the experience that they're getting. Even before that, even if I think about the medical students, I wish that the medical students of today could have more rotation opportunities in some of the value-based care models, like models where the doctors aren't so concerned about
volume,
the volume and the charges and the billing. Are there any models that stick out to you that could help address some of the gaps?
Yeah, it's a great question. So I think, we do have to, models that move away from fee for service as their dominant payment system are the models that are going to really address that. In terms of teaching models, the Teaching Health Center program is really kind of addressing what we mean when we say community-based training. And there are studies done by our friends who show that when someone works or trains in a teaching health center model, that resident actually ends up working with rural and underserved populations at much higher rates than the typical primary care resident trained the typical way in an academic health center. I think there are models of teaching out there. There are models of practice out there. I know you two work in such a model where it's not always just a transaction. You come in, I get paid. You come in, I get paid. The more that you come in, the more I get paid. That's really not the way to take care of a population.
Another problem is like just the time that it takes. Last year, Dr. Dan, I was complaining to Dr. Dan, my wife scheduled a primary care appointment for me, and it took 4 months.
I know.
4 months to get in, and it was such a rushed experience. And then I heard when you were giving the presentation a few weeks ago, I mean, we know that the wait times to get in, especially as a new patient, long, but what was shocking to me are the percentages of people who don't have a regular access. I mean, we think, at least with kids, at least in America, children should be, every child has access to a pediatrician, but that's not the case. And then the number of adults who don't have it it's even higher. I'd love for you to touch on that and to share some of those shocking numbers.
Yeah, so when we found that over a quarter of the US adult population does not have a usual source of care. That is a pretty large number when you think about it. And this is, post Affordable Care Act. So there's been insurance coverage. It's not necessarily an insurance issue, though there are probably still insurance barriers that result in that. And then 13% of children. I mean, that's crazy because all children are covered. 13% of children do not have access to a usual source of care. And in the Milbank scorecard, where we write about, it's called No One Can See You Now. So it's exactly what you're talking about. Even those of us who live in areas where there are primary care physicians readily available, we're not in remote areas, we have good insurance. It's taking, 4, 5, 6 months to see a doctor. It's kind of ridiculous. And so we outline the 5 reasons we think why that's happening, why no one can see you now. And it goes back to what we're talking about here. It's the workforce shortage that's worsening. We're not training people to be primary care doctors. We're really not. Even if they go into primary care as a residency, they're looking at the primary care practice when they're training and saying, you know what, maybe I'll subspecialize and become a cardiologist. That seems like a better track for me. And so, they're not going into primary care. We're not investing enough. We're not investing enough in the infrastructure of our primary care offices. You're a student, you go rotate with a primary care physician, they're having to do a prior auth, they're having to do a prescription refill, they're having to answer questions on the phone while they see patients. They just seem frazzled. You're not going to want to go into that. Technology, as you guys know, it's a barrier right now. And then
You mean the technology didn't help alleviate all the burdens?
it can if done right, but no, it has not. And then finally, we're not really researching primary care the way we should. We're not really spending enough money. We spend a ton of money looking into cancer treatment. We spend a ton of money looking into, these great medications to solve advanced cardiovascular issues. We don't spend that much money looking at primary care systems and what is working and what is not, and why it's not working or why it is working, so that we can implement and scale.
But Dr. Dan, you didn't mention the cancer treatment in that list early on.
Well, I'm sure in certain cancer patients it does prolong life expectancy, but for an entire population, it doesn't. It didn't make the cut of the top 5. So yeah. So, again, that's open evidence, which I find to be pretty good. But I mean, I didn't spend 3 hours in the medical library looking all this up. I just spent a few minutes querying open evidence this afternoon before we were going to do this. So, but you're right. I mean, if you have cancer, you want to treat cancer, right? I mean, that's the reason most of the large health systems, they have the people who have had cancer and survived, they tend to be very generous donors. And so it does make for good donations. People who had their blood pressure treated for 30 years and lived a few years longer don't necessarily feel all that grateful about it, right?
No, yeah. And people who, got their screening test to prevent that cancer that, they could have had also don't necessarily donate to primary care, right? Or the people who got their immunizations, so they were, safe from infectious disease and they never got that infectious disease. It's those things that we do that we know help the population as a whole, but it's just not as exciting is probably the wrong word, but it's not as acute, right? It's over a long period of time. So it's hard to motivate someone when it's just they were taken care of well for their entire life.
Atul Gawande wrote an article a few years ago, The Heroism of Incremental Care. I think that's what we're talking about here. It makes a huge difference, but it has to be done day in and day out. What do you think about what are the right teams for doing this? Because obviously you've got to support it to learn how to develop the teams. And, when I was, again, back in the dark ages, when I was a resident, you had a nurse and a front desk person and they roomed and that was your team, right? And you could ask somebody to call in a prescription or call the patient at home. But now it seems like there's a shortage of medical assistants or even the advanced practice providers who are willing to work. My wife's niece is a PA, and she was working in a primary care setting, and until she could get a job in a gastroenterologist's office, she finds the gastroenterologist's office much more peaceful and much less stressful. And so, what kind of teams do we need to do this? And then, how do we support them to make it a place where it's fun to work rather than a place that they're trying to get experience until they can move on to something else?
Right. I think the structure of the team kind of depends on the community that you're serving, right? I think if we're talking about in general, I do think that a behavioralist is essential in almost every primary care practice. We know that behavioral health, which includes mental health, but isn't only mental health, is a huge issue in almost every chronic disease that we deal with, right? And so having a behavioralist, I think, is essential. Yes, the medical assistant is essential. And I think more importantly than just the medical assistant, a continuous medical assistant. All of us know what it's like to have an MA that's there for 6 months and then leaves, and then a new MA that's there for 6 months and then leaves, or even to have maybe the same pool of MAs, but every time you're in clinic, you're working with a different one. That is not as good as having kind of that real tight teamlet structure of the doctor with the same MA all the time, right? Yeah, and your point about the advanced practice providers, I think that's well taken. They're really essential members of the team. They really can help offload some of the pressure from physicians and can see patients, on their own. They definitely see different, in the literature, see different types of patients than physicians do, and different numbers, but they're so essential. But just like us, just like physicians, the same forces that are driving us out of primary care are driving them out of primary care. It's totally fair that PA would want to go work in a GI office because they're going to get better pay and the practice environment, as you said, is a lot calmer. So So I think that they're essential, but our data is showing that only 30% currently are working in primary care. So even though I think for nurse practitioners, it's something like 70% are certified in primary care, meaning family nurse practitioner or something like that, only 30% are actually working in primary care. So it's the same problem that physicians have. And when you don't have that team, enough people to pull from to create that team, it's a problem. We don't only have a physician shortage in primary care. We have the NPPA shortage in primary care. We know we have a nursing shortage overall in the country, not only primary care, but everywhere. So it's really hard to get that team that you need.
But even the people who go into the primary care specialties, if you go 5 years out, a significant portion of them don't wind up actually practicing longitudinal primary care, correct?
Absolutely. Yeah. Look at me, right? I'm only there 20% of the time now. And I know that, my career path is probably not the typical one, but look at a typical primary care physician. A lot of them are going to telehealth only, urgent care, hospitalist work, because it's a better lifestyle. You can't blame them. But that means that the pool of continuity providers is dwindling probably even more than our data shows, because our data can't tease that out.
I was in clinic yesterday, and with every patient, the point that came up is one of the front desk people, his last day was today.
Aw.
You can imagine, very similar like community health center, our locations where we practice. It's most of the patients live within a few mile radius, and they become closer with the staff. I mean, they're close with the doctors, of course, but they're closer with the staff. The staff do all the phone calls and all preparing all the social events and everything. And I used to think my background is community health. So I started at a community health center before coming over here. And I used to think, all we need to do is just have these centers, like these homes, just have just have these centers there where people could come for social stuff. And as long as the center is there, people will trust that center more than they would trust the emergency room. We used to have a penny tax in Hillsborough County that went towards indigent care. So our unfunded patients would then get funded through this penny tax. And at the time, I thought it was a uniquely Hillsborough County problem that all the money was going to these unnecessary emergency room visits. I didn't realize that it was such a big problem. We don't know, and our residency and all that. But what I have learned now since moving out of that and moving into the full risk model, it's like what you said. It's not just having the place, but having the continuity of the doctors, and then the doctors also working with people who understand. I mean, before everything had to be documented in a computer, it was just people talking with each other. We'd make rounds. When I did residency, it was in the time when we transitioned from paper charts to the computer. And we were very excited about the transition to the computer. I was excited. I thought it was going to be like an amazing experience. Like, I had an image of that Tom Cruise movie with him like sliding the screens across and having these amazing cuts. It wasn't anything like that. But I remember when we'd make rounds, everybody would come, and I knew my people. They would come. The tech would come and say, "Hey, so and so's family member, that or something." They didn't have to go on the computer and document, so and so's family members, whatever. And now they got to find places to document all these things, and then we got to go find all that stuff. And so, in the models where the patients are coming in and they're seeing a different person all the time. And then let's go back even more with the doctors. The doctors not interacting with each other well. The doctors and the teams not interact because they're constant change and constant motion. Obviously we know a headache can mean a whole lot of different things. We're in the middle of clinic and somebody calls into the center saying, "Hey, I've got a headache." If it's my go-to assistant, would know how I'd like to handle a headache with that particular person, as opposed to something, I don't know if I know that there's a lot of studies done with continuity and the value of continuity, but I don't know if there's like a lot of work that's done with just the continuity of the teams?
So I think there's some coming out or that came out of I think UCSF a while back with Kevin Grombach and Tom Bodenheimer that showed kind of like the importance of that teamlet model. I think, although you'd have to check me, there's data that that continuity of that teamlet model is important. I don't know whether it's quantitatively looked at or qualitatively looked at. But you're right. I mean, we can even just talk about it as anecdotal experience. 3 different doctors here who've worked in multiple different environments. We all know that that is true. We just know that's true. We see it all the time. It makes such a big difference. Even if we can't prove that it makes a difference in our patients' health outcomes, which I think we could. I think we could all point to lots of stories where it made a difference. It makes a difference in our mental health and how many patients we can see and how long we can survive in the practice to have, you know, that continuity and that MA that is really just your team member and really helps make things easier for you. I think that it's invaluable. There are lots of studies that show, you're right, how important continuity is. And also looking at continuity with a provider versus continuity with a practice, that's probably the next step that we need to examine, because our data is showing that more people now have continuity with a place or a practice than a provider. It seems to be the way the population has moved, whether they want to or not. So the next series of studies really should start to examine what that type of continuity does for outcomes. Maybe it's okay. Maybe if you have a really well integrated system, it's okay that, you know, my patients are coming in to my practice and that's who they consider their medical provider and not to Dr. Jabbarpour specifically. But I guess it remains to be seen.
But I think you're getting to the point that if we work as a team, if the 3 of us were in a practice together, and I've been in practices like that before where I knew how Yalda wants to do something or how Faisel wants to do it. So if you weren't in the office and your patient showed up, I would know how I usually do it, but I would also know how you usually do it. And unless there's a compelling reason to do it my way, for your patients, I would tend to do it your way. And so there was some continuity there. And we just can't be there. I mean, what's the statistic that if we did all the preventive care, PCP did all the preventive care they needed to do for their patient panel, they would spend 26 hours a day working or something like that. And so we can't be there all the time. So I think, although I'm forgetting, I think it was Bob Phillips I was talking to about this, and he had a pretty good idea that continuity with practice and continuity of PCP were both important, but they were important for different reasons, and that you got some things out of slightly larger groups. We probably need to be looking at what the optimum size group is, right? I mean, if you're coming into a health system with 200 doctors and you're calling that the group, that's probably not the same as if you're coming into the office where 3 to 5 or even 10 people practice and they know each other and they know how each other does it. But I don't know. What's your thought? How do we, I know I saw one of your op-eds and you were talking about AI as being a possible solution, but we all thought that computers were going to be the solution, right? And the computers in a lot of ways, turned into coding and billing machines. So how do we work with AI to make sure that AI helps support the doctor, especially the primary care doctor, instead of turning them into another slave? Now, not only now are we the slave to the computer, we're the slave to the AI in the computer.
I think there are lessons to be learned from how that EHR was rolled out and implemented. And I think one of the big lessons is that more primary care physicians should have been sitting at the table of development and implementation of those EHRs. We are now, but this is 2 decades later. We should have been there right when it was starting and say, even now, the EHRs, they're not only a billing platform, but our EHR is really designed for the inpatient team, not the outpatient team. So it shows you like who is really sitting at the table in development of those EHRs. This is the time where AI is developing fast. It's going to it's already entered our practices, and it's going to continue to enter our practice whether we want it or not. We need primary care clinicians sitting at every table of every medical practice, every AI company that is developing these things, because we need to learn the lessons from the past. If we really just count on, right, like the computer scientist or high level management at a health system or a technology system to be developing these things, or even physicians who aren't necessarily primary care physicians or don't know much about primary care to be developing these things, we're missing the boat completely. So I think that's one lesson to be learned right now in terms of how to implement AI that will help us and not hurt us.
Yeah, and I would go even one step further. I don't think we're telling people to, or at least I wouldn't. I would say we need people who are seeing patients and they're spending 20 or 30% of their time working on the AI and the technology rather than just completely abandoning the patients, because that works for a few years, but then you're always going back to thinking about how you did it before, not what's happening today. And it's pretty important to be eating your own cooking as you're making changes there, going back in the clinic and see how it's working.
100% agree with that. Yeah, absolutely. We need people who are practicing, who are seeing continuity patients on a regular basis to be part of those teams that are developing these tools.
Dr. Jabbarpour, thank you so much for such a great conversation. I'd like to end it on a dream question, if it'd be all right with you. If we could dream for a moment, and suddenly we find out, oh my God, we're gonna double or triple the investment in primary care. What changes for the students, especially the students and the residents? Like, what changes do you think that we'd see in our healthcare delivery system over the next 10 years?
Yeah, I think if we did that, and assuming that money went into the primary care practices, right? I think the changes that you see is that we can invest in robust teams. And when you can invest in a robust team, that's going to lead to continuity of the team, right? If you have a great high functioning team, no one's going to want to leave their job. They might leave because of life, something happens, but they're not going to leave because they're not satisfied. So those really robust, high functioning teams, what does that lead to? That leads to a doctor who can be a doctor, who can see their patients, who can do what they were trained to do. We're not secretaries, we're not billers and coders. We're really taking care of our population, and we're happy doing that. And and also if you increase that investment and do it right, I mean, I'm really excited about how these AI tools can really help us, right? We have ambient listening now in our clinic, and it's learning, it's becoming better, but even in the last couple months since we've implemented it, my life just feels so much better when I'm in clinic. I turn something on, I talk to the patient, and my note is done. What? And just imagine how great it could be if we had a high functioning team. The doctor could be a doctor. We didn't have to write our notes. Ugh, the dream. And I think investment will get us there.
It's incredible to think how much more compassionate and effective our whole healthcare delivery system could be with better investment in primary care. Dr. Jabbarpour, thank you so much for joining us today. This was a fabulous conversation.
Thank you both. It was great to see you again.
What are your thoughts on investing in the future, healing access to primary care? You've heard ours. Now we want to hear yours.
Email us at faiselandfriends@gmail.com, and your question could be featured on the podcast.
If you like this episode, leave us a review and tell us how we're doing. And don't forget to subscribe wherever you listen to podcasts so you never miss an episode.
Connect with us on social media by following Faisel and Friends.
And follow Primary Care for America on LinkedIn and Twitter.
I'm Dr. Faisel.
And I'm Dr. Dan.
And thanks for listening. This podcast is brought to you by Primary Care for America Collaborative and produced by Split Prism Productions.